Welcome to the Cardiac MR Learner Series, a unique video tutorial program under the aegis of Indian Association of Cardiac Imaging. This program is focused on beginners and intermediate images with learning happening through short sessions and case-based discussions. We are grateful to experts from different parts of India who have helped us in putting this program together. Please do feel free to give us your feedback so we can continually improve such training opportunities. This session is brought to you by Dr. Richa Kothari, who is a consultant cardiothoracic radiologist in Narayana Institute of Cardiac Sciences, Bangalore. Her areas of expertise include cardiac CT and MRI in adults and children, and thoracic and vascular imaging. She received the 2018 Regional Award by the European Association of Cardiovascular Imaging in Barcelona, Spain, and holds a Level 3 certification from the same association. She has won multiple research presentations at national and international level and is a executive committee member of the Indian Association of Cardiac Imaging. She has co-authored multiple textbook chapters and is part of the DNB teaching program.
Hello everyone, I am Dr. Richa Kothari. I am a cardiothoracic radiologist working at Narayana Hrudayalaya in Bangalore. In this video, I'll be talking about the role of cardiac MRI in valvular heart disease. Echocardiography, as we know, is the major modality for assessing valve disease. Cardiac MRI can provide not only standalone assessment but also add value and complement echocardiography. So in this video, we'll see how do we use cardiac MRI to assess the valves, when do we do it, and what additional information does it provide. Available data from the Western world shows that the prevalence of significant valve disease is about 2.5%, and it is seen to increase with increasing age. Cardiac MRI not only detects valvular heart disease and which valve it affects, but also further characterizes whether stenotic or regurgitant or a mixed lesion, and helps to determine its severity along with the possible cause. MRI also, as we know, is the gold standard for ventricular volumes and function assessment. Cardiac MR has the added advantage of picking up ancillary findings, and multiple studies have also shown that it helps in prognostication of these patients. Each case of valvular heart disease needs to be assessed for anatomy, function, and quantification. Cardiac MRI has the advantage that we can scan in any plane. This is especially helpful for right-sided valvular heart lesions, which might be difficult to assess on echocardiography. Also, it provides anatomical information which is as good as transesophageal echocardiography. However, it has a limitation in that each slice of cardiac MRI is at least 6 to 8 millimeters thick. So there might be partial volume artifact, especially in the in-plane view of the valve, because the valves are just 1 to 2 millimeters thin. Another problem may be that we may not see small masses or vegetations on the valves. One way to avoid this problem is to take multiple slices which are perpendicular to the plane of the valve. For quantification of the valvular heart disease, one of the ways to quantify is to use phase contrast imaging. Phase contrast imaging across the valvular lesion gives flow direction, quantification, and also gives us the velocity, which may help in calculating the gradient. So this is an example of the curve obtained after analysis of the phase contrast across the ascending aorta. we get a graphical representation like this, which shows that the stroke volume across the valve is 37.14 ml with forward flow of 37.34 and backward flow of just 0.2, which is represented in this graph as this is the forward flow and this is the slight backward flow. So it calculates the regurgitant fraction as 0.5% and also gives us the peak velocity as 90 centimeter per second. So these can be used for grading in the valvular lesions. For grading of stenotic lesions, the criteria necessary are valve area, velocity, and gradient. For valve area assessment, we can obtain an in-plane cross-section across the valve and actually measure it by planimetry, which is an advantage of MRI compared to echocardiography, where the valve area is measured by calculation. However, care must be taken that it is exactly at the valve tip. Change in angle or location will give an erroneous result. These are few studies which assessed cardiac MRI planimetry versus transesophageal planimetry in aortic lesions, and it was discovered that cardiac MR was equal, if not better, than transesophageal echocardiography. Phase contrast imaging will also give us the peak velocity across the stenotic lesion. As we can see in this video, that this area is showing aliasing. If we use these values to calculate the velocity and the gradient, we'll get erroneous results. So in such cases, in stenosis where the velocity is high, we need to increase the Wenck and repeat the phase contrast imaging at the same level. In this image, we can see after increasing the Wenck that there is no aliasing any longer. So these values can be used for the calculation. Gradient is calculated using the simplified Bernoulli's equation of 4 times velocity square. For grading of regurgitant lesions, regurgitant volume is needed, which can be obtained by phase contrast across the valve directly or indirectly by subtracting the forward flow across the regurgitant valve from the ventricular stroke volume. Regurgitant fraction is nothing but ratio of regurgitant volume to the stroke volume of the regurgitant valve. Valve area of the regurgitant valve can also help in prognosis of the patients. Now let's see individual valve lesions. Aortic stenosis. The common causes are congenital. Usually it may be associated with a bicuspid aortic valve or it may be rheumatic in etiology. Usually it is associated with left ventricular hypertrophy. On CT scan, we may see calcification in the valve along the valve leaflets or commissures in CT. MRI will help us with the planimetry, the flow quantification and peak velocity, and with the ventricular function and mass. This is a case in which we can see this is the 3-chamber cine view and this is the LVOT view, where we can see the aortic valve leaflets show restricted opening with flow acceleration across it, suggestive of aortic stenosis. This is another case where this is a cine 3-chamber view which shows thickened valve leaflets with restricted opening and associated flow acceleration. This is a cross-section valve view obtained across the tip of the valve, which shows a functionally bicuspid valve with restricted opening. This can be used to calculate the valve area. This is another case where we can see bicuspid aortic valve and cardiac MRI. The advantage is seen here, where we can also pick up associated lesions of aortic coarctation. According to the American Heart Association guidelines, The classification of valve severity: when the aortic valve area is less than 1 centimeter square or the jet velocity is more than 4 meters per second, it is classified as severe aortic stenosis. Aortic insufficiency: the causes may be primary due to valve disease like degenerative, rheumatic, or due to infective endocarditis, or it may be secondary to aortic root dilatation in cases of Marfan's or aortic dissection or aneurysm. It is usually associated with left ventricular dilatation. In this case, we can see this is a three-chamber cine view, and this is the LVOT cine view, where we can see there's thickened aortic valve leaflets with restricted opening and flow acceleration, and this is the regurgitant jet. Similar findings we can see on the LVOT view. So this is a case of mixed aortic valve disease with aortic stenosis as well as regurgitation. We can also scan patients post aortic valve replacement, as is seen in this case, to assess for post-operative function. Mitral stenosis, the most common cause is rheumatic heart disease. It is usually associated with left atrial dilatation. Mitral regurgitation may be primary due to degenerative, congenital, or rheumatic valve disease, or it may be secondary to mitral annular stretching due to left ventricular dilatation. It is associated with left atrial and ventricular dilatation. Cardiac MR assessment of left volume and functional may help decide further management in these patients. Also, cardiac MR can be used to calculate the E by A ratio. In such cases, when the phase contrast imaging acquired across the mitral valve can be used to give the E by A ratio, which is the ratio of peak velocity due to left ventricular dilatation in early diastole, which is the E wave, to the peak velocity due to atrial contraction in late diastole, which is the A wave. E by A ratio with deceleration time obtained helps to determine the phase of diastolic dysfunction in these patients. This is a case where we can see thickened mitral valve leaflets with restricted opening, and this is the regurgitant jet. Similarly, on the two-chamber view, restricted opening of the mitral valve leaflets with regurgitant jet. So this is a case of mixed mitral disease with mitral stenosis and regurgitation. We can also see the associated left atrial and left ventricular dilatation. Same patient, this is the three-chamber view, which also shows the same findings of thickened mitral valve leaflets with stenosis and regurgitation. This is a short axis view which is acquired across the tip of the mitral valve, and we can see the valve area. This view can be used to obtain the valve area. By the American Heart Association guidelines for mitral regurgitation, more than or equal to 60 ml of regurgitant volume with more than 50% of regurgitant fraction determines it as a severe mitral regurgitation. The mitral valve has two leaflets, as we know, the anterior and the posterior. It is composed of three scallops on each leaflet. So this is the A1, A2 and A3 scallop on anterior, and P1, P2 and P3 scallop on the posterior mitral valve leaflet. Cardiac MRI has the advantage of being able to scan each and every individual scallop. So when we cut across in this manner, we get views like this. So this is the A1 P1 scallop, A2 P2 scallop and A3 P3 scallop. So we get views with opposing scallops, which helps us to determine if it is a localized lesion rather than a entire valve disease, which can be used for just localized repair of the scallops instead of entire valve replacement. Tricuspid valve disease is rarely isolated. Usually it is seen with other valvular heart diseases in rheumatic, or it may be seen in infective endocarditis in IV intravenous drug users. One common indication is to determine whether it is a primary tricuspid valvular disease or a RV cardiomyopathy. What the clinician wants to know is whether valve surgery will solve the problem. So we need to rule out RV cardiomyopathy in such patients. One marker which helps us is dyskinesis or akinesis of the right ventricle with right ventricular valve enhancement will be more in favor of cardiomyopathy rather than a primary valvular disease. Pulmonary valvular disease, the commonest lesion is seen in congenital heart disease, commonest being tetralogy of Fallot, as we can see in this case with pulmonary stenosis. One common indication of cardiac MRI is post-tetralogy of Fallot repair patients to look for pulmonary regurgitation and right ventricular dilatation. As we can see in this patient, there is severe pulmonary regurgitation. One other indication for cardiac MRI is presence of masses on valves, common causes being calcification, thrombus, vegetation, papillary elastoma, or myxoma, which is seen in this case. Multiple studies have shown that myocardial fibrosis is an independent indicator of mortality and affects the prognosis of patients with valvular heart disease. So, cardiac MRI has the advantage of good resolution, good delineation of morphology and cause. The quantification can be done quite accurately, and the ventricular function obtained is the reference standard across all imaging modalities. It can be scanned even in patients who do not have good acoustic windows in echocardiography. With limitations of it being costlier, newer modality, less available compared to echocardiography, and patients with implants and prosthetic valves might show artifacts while scanning. So to conclude, cardiac MRI is good, especially in patients with poor acoustic windows for evaluation of valvular heart disease. It also picks up extravalvular changes in these patients. It is the standard of reference for volumetric analysis, and it allows direct and accurate measurement of flow and valve area in these patients. Even though echocardiography is the dominant imaging modality in valvular heart disease, cardiac MRI is an excellent alternative and confirmatory tool. Thank you.